2. Defining conduct disorder. Conduct disorder is one of the psychological disorder which is a repetitive, persistent and continuous violation of the recognized values and norms of society and disrespect for the rights of others. The symptoms of conduct disorder are severe and intense, including lying, stealing, excessive aggression, cruelty towards animals and children, as well as damaging both private as well as public property without any feelings of remorse, which makes it a vicious cycle and further grows into an antisocial personality disorder. This disorder is common among adolescents and children. 2.1. Clinical picture and prevalence of conduct disorder. Conduct disorder is unacceptable conduct exhibited by the child both at school as well as at home with both peers and parents. These children show a variety of other problems like alcohol abuse, drug abuse, and delinquent behavior who show deficits in social behavior. They are not emotionally attached to their family members and friends and exhibit an overtly aggressive, hostile, disobedient and destructive behavior. They generally display temper tantrums, with stealing and lying being common. At school, they bully others and often bunk school while being involved in activities like vandalism, robbery and homicidal acts. Children with conduct disorder generally suffer from anxiety, depression, substance abuse and attention deficit hyperactivity disorder. Girls are at a higher risk of developing comorbid disorders like anxiety, substance abuse as compared to boys. Conduct disorder is at its peak around the age of 17 years. These children are often involved in law breaking, stealing and vandalism and drop such behavior when they grow older. Moffat 1993 has concluded that some children show a persistent pattern of antisocial behavior. Conduct disorder starts at the age of 3 years and continues to grow from stealing, mischief, lying to antisocial behavior when they reach adulthood. He proposed that conduct disorder is more common among boys than in girls. He concluded that children whose behavior becomes more aggressive and antisocial as they reach adulthood have other problems like absenteeism from school and are often underachievers or underperformers. They are involved in more violent activities as they grow old with a high dependency on drugs. They are impulsive and commit crimes. However, some of them become better as they reach their late 20s and early 30s. Psychology paper number 15, Clinical Psychology. 2.2, DSM-IBTR, Criteria for Conduct Disorder. A. This disorder is a repetitive and persistent pattern of behavior in which the basic rights of others or societal norms or rules are violated, as manifested by the presence of 3 or more of the following criteria in the past 6 months. They show aggression to people and animals. 1. They bullies, threatens others. 2. They are involved in physical fights. 3. They keep dangerous weapons with them and harm others. 4. They are usually cruel to others. 5. They are cruel to animals. 6. They steal others' property. 7. They force others to sexually involve with them. Destruction of property. 8. They are involved in causing damage to others' property. 9. They destroy others' property. Deceitfulness or theft. 10. They jump into someone else's house, building, or car without permission. 11. They often lies to obtain goods or favors or to avoid obligations. 12. They has stolen items of non-trivial value without confronting a victim. Serious violation of rules. 13. They often stays out at night despite parental prohibitions, beginning before age 13 years. Psychology paper number 15, Clinical Psychology. B. The disturbance in behavior causes clinically significant impairment in social, academic, or occupational functioning. C. If the individual is age 18 years or older, criteria are not met for antisocial personality disorder. The severity of the disorder should be specified as follows. Mild, when conduct problem causes minor harm to others. Moderate, when the severity of conduct problem is more than mild and less than severe, it come under the moderate category. Severe, when the child causes a considerable harm to other people or their property, it comes under severe category. Source, adapted with permission from the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, text revision copyright 2000, American Psychiatric Association. 3. Causal factors in conduct disorder. There are several factors which contribute to the development of conduct disorder. 3.1. A self-perpetuating cycle. Research suggests that a genetic predisposition leads to the development of the disorder along with neuropsychological problems, their temperament, insecure attachment to parent and low intelligence. They have less control over their actions and behavior, which may be one of the prime reasons for the disorder itself. Their parents find it difficult to provide them a secure attachment because of their tough temperament. Mild neuropsychological deficits are also found in these children who are unable to make plans or monitor themselves, which accompanies their aggressive and impulsive behavior, bringing in long-term difficulties later in life. Research studies conducted in the United States, Sweden and Denmark regarding the hereditability of criminal behavior rather than conduct disorder has found that both genetic and environmental factors play an important role in the development of conduct disorder. Although the prevalence rate of occurrence is different for boys and girls, but genetic and hereditability component of is the same in both boys and girls. Both twin and adoption studies concerning antisocial behavior indicated that 40% to 50% of antisocial behavior is heritable. Aggressive behavior like fighting, cruelty and destroying property is truly heritable, whereas delinquent behavior such as truancy, stealing may not be heritable. 3.2. Neuropsychological factors and autonomic nervous system. Neuropsychological factors which lead to the development of conduct disorder cause problems relating to memory, planning, difficulty with executive functioning and problem solving. These problems have been found to be common among children with conduct disorder who at an early stage experience low IQ, which is though not related to school failure or their low socioeconomic status. Psychology paper number 15, Clinical Psychology. Research studies also indicate that abnormalities in the autonomic nervous system are found in children with conduct disorder. They have lower arousal levels as compared to children without conduct disorder. Adolescents with antisocial behavior were also found to have lower arousal levels and lower levels of resting heart rate than adolescents not exhibiting such antisocial behavior. Adolescents who show antisocial behavior do not show fear of punishment as compared to children without antisocial behavior. They do not show fear while doing such antisocial activities and have no fear of punishment even if they are caught while doing so. 3.3. Psychological and socio-cultural factors. In our society, children refrain from doing antisocial activities not because they are illegal, but because they are following the established norms of good conduct in the society and are filled with guilt and remorse if they violate these established values and norms. Child development thus involves a moral awareness of what is right and wrong. Children without conduct disorder have the ability to follow the rules and norms of the society. However, children with conduct disorder seems to be deficient in this moral awareness as they violate these rules and regulations of the society without any feelings of guilt or remorse. Behaviorists feel that modeling and conditioning play an important role in the maintenance and development of conduct disorder. Children who face child abuse are likely to become aggressive as they grow as they imitate others doing such aggressive acts. This behavior is likely to be maintained. They learn from the peers who are engaged in antisocial acts and enjoying high-status possessions. Parental bringing up with a lack of discipline or inadequate parenting are often associated with conduct disorder. Children who are not punished for wrongful acts such as stealing, lying, damaging private or public property become more and more aggressive, which leads to them developing serious conduct problems. Research studies suggest that ineffective parenting like parental neglect, rejection and lack of monitoring is also associated with conduct disorder. If the parents have a disturbed emotional status, their children also become antisocial and develop serious conduct problems. Low socioeconomic status, parental depression, parents have unstable marital relationships and stress all increase the probability of conduct disorder. Kenneth Dodge gave a social information processing theory of child behavior as to how children process social information and its impact on their behavior. He says that aggressive children have a bias in their cognitive processes. Who then interpreted ambiguous acts such as bumped in line as exhibiting hostile intent of others, which makes them retaliate aggressively even if such actions had not been intended to invoke such behavior by the other person. This creates a vicious cycle where others may react more aggressively towards such children, fueling even more aggressive responses from the latter. Therefore, these deficits in the social information processing predicts antisocial behavior among adolescents. Unemployment, poverty, delinquency, lack of access to educational facilities and a disturbed family life are all contributory factors to conduct disorder. The combination of one or more of these factors combined with an early antisocial behavior predicts a trend of criminal activities. 3.4. Peer influences. Research suggests that peer pressure instills aggressive and antisocial behavior in children. Sometimes peers accept or reject such children who often have affiliations with deviant peers. When peers reject such children, they become aggressive and many of them show attention deficit and hyperactive disorder. Many studies indicate that rejection by peers is generally related to later aggressive behavior. When children have associations with deviant peers, they also become delinquent in their Psychology paper number 15, Clinical Psychology. Behavior. When the aggressive children rejected by peers, they are also unskilled and unable to adjust socially, they exhibit their tendency towards antisocial behavior. These socially rejected children have a tendency to become antisocial and delinquent. They grow into adults with antisocial behavior. 4. Treatment of conduct disorder. In the treatment of conduct disorder children, their family members, peers, neighborhood and school are all involved providing social support. 4.1. Family interventions. Families and parents play a very important role in the treatment of children suffering from conduct disorder. If they interfere in the early stage of conduct disorder, its impact is visible. The parents are advised to reinforce and motivate their pro-social behavior. They should consistently reward their positive behavior and discourage antisocial and aggressive behavior. Parents are taught how they can modify the conduct of the children. Management training is given to the parents, in which various techniques are taught to parents, as to how they can use reinforcement techniques like privileges are given to them, if they display a positive behavior and withdrawal of incentives if they are involved in antisocial and aggressive behavior. Parents' management training programs prove to be more effective when they work in coordination with teachers of the school. Teachers observe the behavior of the children at school and parents keep an eye on children at home. When teachers and parents work together, it proves to be more effective and fruitful and has been shown to improve the behavior of siblings also. Research suggests that parents of children with conduct disorder are found to be inconsistent in their behavior and often lacking in good parenting skills. Children learn to avoid their parents and copy their aggressive behavior. Divorced, burdened parents have no time or money to learn parental training programs because of which children suffering from conduct disorder are shifted from one place to another, perceiving this as rejection not only by society but also by their parents. If the environment is warm and healthy, it brings about positive changes in their behavior. However, these treatments have been found to be only temporarily effective. 4.2. Behavioral techniques. Behavioral techniques are found to be effective in treating children suffering conduct disorder. Parents are taught control techniques how they can modify their antisocial and aggressive behavior to normal socially acceptable behavior. Parents are taught they can manage the behavior of the children like a therapist. They can reinforce the socially acceptable behavior and discourage the antisocial behavior. Parents should be consistent in their behavior. The changes brought about when parents consistently accept and reward their child's positive behavior and stop focusing on the negative behavior may finally change their perception of and feeling toward the child, leading to the basic acceptance that the child has to badly needed. Although effective techniques for behavioral management can be taught to parents, they often have difficulty carrying out treatment plans. If this is the case, other techniques such as family therapy or parental counseling are used to ensure that the parents or person responsible for the child's discipline is sufficiently assertive to follow through on the program. Psychology paper number 15, Clinical Psychology. 5. Summary. Children with conduct disorder display persistent aggressive and antisocial activities. They show a variety of problems like stealing, drug abuse and damaging both public as well as private property without any feelings of guilt or remorse. As they grow into adulthood, conduct disorder transforms itself into antisocial behavior. There are many factors which contribute to the development of conduct disorder, such as a genetic predisposition to develop conduct disorder, environmental factors such as poverty, unemployment, dysfunctional interpersonal relationships, and inadequate development of moral awareness of the norms and rules of the society or of what is right or wrong, along with negative peer influences, play an important role in the maintenance and development of conduct disorder. The most feasible as well as promising method of treatment of conduct disorder is through a multiple support system involving peers, parents, family members as well as teachers who work together in enhancing a pro-social behavior among such children. 2. Elimination disorder. Elimination disorder is of two types: enuresis and encopresis. The term enuresis refers to the habitual involuntary discharge of urine, usually at night, after the age of expected continence, age 5. In DSM-IVTR, functional enuresis is described as bedwetting that is not organically caused. Children who have secondary functional enuresis have never been continent. Children who have secondary functional enuresis have been continent for at least a year but have regressed. Enuresis is diagnosed for children of at least 5 years of age when bedwetting or involuntary urination occurs more than once a month a week for at least 3 consecutive months. If the frequency is less often, the diagnosis may still be made when the bedwetting causes significant distress or impairment in the child's functioning. American Psychiatric Association, 1994. For most children in Western society, the first major confrontation with social expectations for impulse control occurs in the context of potty training. By the age of 3.5 years, the majority of children gain bladder control. But sometimes things do not go as planned. Enuresis is arbitrarily defined as involuntary urination at least twice a month for children between 5 and 6, and once a month for those who are older. It is estimated that between 3 million and 6 million school-age children in the United States suffer from related enuresis. Sheldon, 1996. After elementary school, the proportion of children who have difficulty controlling urination, either during the day or while in bed, drops markedly. At age 12, only 8% of boys and 4% of girls have enuresis. Fryman and Warzik, 1990. There is a marked decrease in enuresis with age, and most who continue to have the problem into late childhood are males. Moreover, in adulthood, enuresis is almost non-existent for females, but approximately 1 to 2% of male remain enuretic, as estimated sample of military recruits. Howden-Liebert, 1984. Most children from lower socioeconomic backgrounds than children from higher socioeconomic classes have this disorder. Consistent evidence also shown that children are more likely to be enuretic if the parent are enuretic. Doles, 1989. Because enuresis generally declines with age, it's reasonable for an enuretic child's parents to wonder how long the bedwetting will continue. Researchers followed approximately 1,200 bedwetters between the ages of 5 and 19 over a 15-year period to see how long it took them to become dry without medical or psychological treatment. Forsyth and Redmond, 1974. Their likelihood of a spontaneous cure or simply growing out of the problem was only 15% per year. Parents of most school-aged enuretic children are generally advised to seek treatment for this problem. Houtzen, Berman and Abramson, 1994. Psychology paper number 15, Clinical Psychology. Enuresis can be troublesome for children, who cannot understand why they wet their beds during sleep. Parents who mistakenly believe that the problem is simply one of laziness often make their children's sense of shame worse. Soiled sheets anger many parents and embarrass many children. Enuretic children tend to avoid visiting friends overnight, going to camp, or staying with their relatives. Those who share bedroom with sibling are often the subject of relentless teasing. The problems of the child with enuresis are compounded by the social consequences of the disorder. Goen, 1998. Parents object to soiled sheets and cloths and they stigmatize the child as immature. Schoolmates and friends are likely to tease the child. These social consequences may create a fertile ground for other serious psychological problems. 2.1 Enuresis defined according to DSM-IVTR criteria. A. Repeated voiding of urine into bed or clothes, whether involuntary or intentional. B. The behavior is clinically significant is manifested by either a frequency of twice a week for at least 3 consecutive months or the presence of clinically significant distress or impairment in social, academic, occupational, or other important areas of functioning. C. Chronological at least 5 years or equivalent developmental level. D. The behavior is not due exclusively to the direct physiological effects of a substance, e.g., a diabetes, spina bifida. A seizure disorder. 2.2 Encopresis. The failure to control bowel movement is much less common than enuresis. Children are not diagnosed with encopresis unless they are 4-year-old or older. The disorder is often associated with physical health problems. Gefkin and Momoko, 1996. But when there is no specific physical causes, encopresis is frequently associated with conduct disorder or oppositional defiant disorder. DSM-IVTR estimated that about 1% of 5-year-olds have encopresis. A study of 102 cases of encopretic children yielded the following. There has been relatively little research on the causes and treatment for encopresis. 3. Causes of enuresis. There are many different causes of enuresis. Parents typically but often mistakenly believe that bedwetting is caused by emotional problems or by extremely deep sleep that prevent children from detecting bladder pressure. Doles, 1989. Disease and infection account for only small number of cases. Most bedwetters do not have disease or emotional problems. During sleep or waking period, they simply fail to respond to cues from their bladders that it's time to urinate. 3.1 Biological factors. There is an evidence that biological factors do contribute to enuresis. Approximately 75% of children with enuresis have first-degree relatives who ever have had enuresis, and the concordance for enuresis is higher in identical MZ twins than in fraternal DZ twins. Abe, Oda, Ikenaga, and Yamada, 1993. So, the more similar a person's genetic blueprint is to a person with enuresis, the more likely the individual will have also enuresis in certain regions on. Psychology paper number 15, Clinical Psychology. Chromosomes 8, 12, and 13 von Gontard and Lemkel, 1997. But additional research is needed to confirm this. It may result from a variety of organic conditions, such as disturbed cerebral control of the bladder. Goen, 1998. Neurological dysfunction, Lunsing et al. 1991, or other medical factors such as medication side effects Took and Buck, 1996, or having a small functional bladder capacity and a weak urethral sphincter Dahl, 1992. One group of researchers reported that 11% of their anoretic patients had disorders of the urinary tract infection, Watanabe et al. 1994. Physical illness can also contribute to enuresis, Goen, 1998. It is not uncommon for children to develop enuresis after experiencing an illness that disrupt their daily schedule and sleep patterns. The link between illness and the onset of enuresis may be direct consequence of a decrease in the physical control of bladder function. But it could also be a result of a stress. 3.2 Psychological factors. A clear-cut example of the role of a stress provided by Dollinger, 1985, who studied the effect of a tragedy in which child was struck by lightning and killed. He collected information about 5th and 6th graders who were aware of the incident. While most of these children reported feeling of anxiety, especially during storms, the most disturbed children experienced nocturnal enuresis. These findings and others suggests that stress can trigger the onset of enuresis. However, most investigators have pointed to a number of other possible causal factors. 1. Faulty learning, resulting in the failure to acquire inhibition of reflexive bladder emptying. 2. Personal immaturity, associated with or stemming from emotional problems. 3. Disturbed family interaction, particularly those that lead to sustained anxiety, hostility, or both. 4. Stressful events, Schnabel-Haug, 1992. Parents typically but often mistakenly believe that bedwetting is caused by emotional problems during sleep or the awaking period. They simply fail to respond to cues from their bladder that it's time to urinate. 4. Treatment. 4.1 Medical treatment. Medical treatment of enuresis typically centers on using medications such as imipramine. The mechanism underlying the action of the drug is unclear, but it may simply decrease the deepest stages of sleep to light sleep, enabling the child to recognize bodily needs more effectively. Dahl, 1992. An intranasal desmopressin has been used to help children manage urine more effectively. This medication, a hormone replacement, apparently increases urine concentration, decreases urine volume and therefore reduces the need to urinate. Dahl, 1992. Psychology paper number 15, Clinical Psychology. The use of this medication to treat enuretic children is no panacea. Disadvantages of its use include its high cost and the fact that it is effective only with a small subset of enuretic children, and then only temporarily. Bath, Morton, Ewing, and Williams 1996 reported that treatment with desmopressin was disappointing but concluded that this treatment had some utility as a way to enable children to stay dry for brief periods of time, for example, at a camp or on a holiday. Moffitt 1997 suggested that desmopressin had an important place in treating nocturnal enuresis in youngsters who have not responded well to behavior treatment methods. It is well to remember that medications by themselves do not cure enuresis, that there is frequent relapse when the drug is discontinued or the child habituates to the medication. Dahl, 1992. Some drugs, namely the antidiuretics or antidepressants such as imipramine and SSRIs, can suppress bedwetting at least temporarily. Wylans, Spencer, Fraser and Biederman, 1998. But often children begin to wet the bed again once the drug is stopped. Even a few dry nights can be an enormous morale booster to a child with enuresis, particularly if it allows the child to visit friends overnight or to go to camp without fear of embarrassment. Antidepressant drugs can have side effects, such as weight loss and cardiovascular problems. For some children, the side effects outweigh the usefulness of the medication. It is now apparent that even though imipramine does result in decreased frequency of bedwetting, it is not a cure. In most cases, Hout, Peterson, and Abramson, 1994. It has not been established as a primary treatment for enuresis that leads to cessation of bedwetting. 4.2 Behavioral treatment. Behavioral treatments have been quite successful with enuresis, and the effects may be more lasting than drug treatment. Goen, 1998. Most common is a procedure that was first described over 50 years ago. Mower and Mower, 1938. The child sleeps in his own bed. Beneath the sheets is a special pad which, when moistened by urine, completes a harmless electric circuit that sounds a bell and awakens the child, which then goes to the toilet. Then they instruct the child to return to the bedroom, change the sheets, reset the alarm, and go back to sleep. To monitor the child's progress, the parents keep a daily chart and for each dry day, they place a gold star on it. Usually, within 3 to 8 weeks of treatment, the child no longer wets the bed. An extensive review of the effectiveness of the bell and pad treatment, approximately 2/3 of the children had stopped wetting. The researchers also reported that less than 1 of every 10 clinic-referred children could be expected to stop bedwetting if untreated. Hout, Berman, and Abramson, 1994. A variation on the bell and pad method involves an all-night training program of intensive training in how to become continent. Azrin, Sneed, and Fox, 1973. This program consists of only 1 or 2 extended overnight sessions, with the therapist present. The child drinks large amount of fluid before going to bed to increase the probability of urinating during the night. Then throughout the night, the child receives practice and positive reinforcement for getting out of the bed to urinate and for urinating in the toilet. The child also receives negative reinforcement for accidents, in the form of reprimands and having to clean and remake the bed. As in the original bell and pad treatment, a chart marks the child's progress. Psychology paper number 15, Clinical Psychology. This is all-night training procedure has been used in several studies with 100% success, although in some other studies, the success rate has been considerably lower. Another low-cost 1-hour group treatment program for enueretics and their parents combining the bell and pad and all-night training methods has been successful in 80% of cases. Houts and Liebert, 1984. This program is cost-effective and efficient in helping children achieve continence. The relapse rate is 23%, compares very favorably with other treatment outcomes. Behavioral treatment is effective with children who are most effective with children who are under the age of 12. Bath, Morton and Williams, 1996. Recent evidence suggests that a biobehavioral approach that is using the urine alarm along with desmopressin is most effective. Mellon and McGrath, 2000. With or without treatment, the incidence of enuresis tends to decrease significantly with age, but many experts still believe that enuresis should be treated in childhood because there is presently no way to identify which children will remain enuretic into adulthood. Goen, 1998. In an evaluation of research on the treatment of bedwetting, Houts, Berman, and Abramson 1994 concluded that treated children were more improved at follow-up than non-treated children. They also found that learning-based procedures were more effective than medication. 5. Summary. For most children, the major confrontations for impulse control occurs in the context of potty training by age of 3.5 years. The majority of children gain bladder control. But sometimes things do not go as planned. Enuresis is arbitrarily defined as involuntary urination at least twice a month for children between 5 and 6, and once a month for those who are older. Consistent evidence has also shown that children are more likely to be enuretic if a parent was also enuretic. It generally declines with age. Encopresis is the failure to control bowel movement. It is often associated with conduct disorder or oppositional defiant disorder. A distinction is made between primary enuresis, where the child never attains bladder control, and secondary enuresis, which occurs after the child has achieved control. Some assumes that primary enuresis is caused by biological abnormality. Enuresis may result from a variety of organic conditions, and neurological dysfunction or other factors such as medication side effects and psychosocial factors such as stress contribute to secondary enuresis. There is also evidence that biological factors do contribute to enuresis. It is also possible that children develop enuresis after experiencing an illness that disrupts their daily schedule and sleeping patterns. The most effective and commonly used psychological treatment is the bell and pad method developed in the 1930s by Mower and Mower. Behavioral treatment are effective in treating children who are below the age 12. Psychology paper number 15, Clinical Psychology. Medical treatment is also proved to be effective in treating enuretic. Antidepressants drugs can have side effects, such as weight loss and cardiovascular problems. For some children outweigh the usefulness of the medication. Imipramine, an antidepressant, initially seemed effective in treating enuretic children. It is now apparent that even though imipramine does result in decreased frequency of bedwetting, it is not cure in most cases. Another medication which has received attention is demopression. This is taken in the form of nasal spray. 2. Introduction. Mental retardation is a condition of a lack of development of the mind, which is particularly characterized by impairment of skills noticeable during the developmental period, which adds to the overall level of intelligence, i.e. cognitive, language, motor, and social abilities. It can occur with or without any other. Psychology paper number 15, Clinical Psychology. Psychology paper number 15, Clinical Psychology. Mental or physical disorder. Mental retardation is thus defined in terms of level of performance as well as intelligence. However, mentally retarded individuals can experience the full spectrum of mental disorders, and the prevalence of other mental disorder is at least 3 to 4 times greater in this population than in the general population. Mental retardation occurs among children throughout the world. In its most severe form, it is a source of great hardship to parents and also a social and economic burden on a society. During childhood, individual with a mild degree of intellectual impairment often appears to be normal. Their sub-average intellectual becomes apparent only when difficulty with school homework leads to a diagnostic evaluation. 3. Diagnosis and assessment of mental retardation. DSM-IVTR defines mental retardation as the American Association on Mental Retardation. The American Association on Mental Retardation, AAMR, which has its own similar definition of mental retardation, has a cutoff score of approximately 70 to 75. King et al., 2005. The second criterion of both the DSM-IVTR and the AAMR definition for mental retardation calls for the final criterion. The second criterion of both the DSM-IVTR and the AAMR definition for mental retardation calls for the final criterion for mental retardation is the age of onset. The characteristic below average intellectual and adaptive abilities must be evident before the person is 18. The imprecise definition of mental retardation brings up an important issues. It perhaps more than any of the other disorder is defined by society. Initial diagnosis of mental retardation occurs very frequently at ages 5 to 6, around the time schooling begins for most children, peak at age 15 and drop off sharply after that. During early childhood, individuals with only a mild degree of intellectual impairment, who constitute the vast majority of the mentally retarded, often appears to normal. Their sub-average intellectual functioning becomes apparent only when difficulties with schoolwork leads to a diagnostic evaluation. When adequate facilities are available for their education, they can usually master essential school skills and achieve a satisfactory level of socially adaptive behavior. 4. Levels of mental retardation. 4 levels of mental retardation in DSM-IV are recognized, with each one corresponding to a range of IQ scores. For diagnosis, EQ is not the only source. The person with low IQ scores but adjusting adequately would not be considered to have mental retardation. When deficits in adaptive have been found, only then IQ criterion is being applied. Since 1876, AAIDD has been in existence, and it publishes guidelines routinely for defining and classifying mental retardation that are more centered on determining what steps are required to facilitate higher functioning and less on identifying severity of disability. According to AAIDD, significant limitations both in intellectual functioning and in adaptive behavior is expressed in conceptual, social and practical adaptive skills characterizes mental retardation or intellectual disability. This disability originates before age 18. Psychology paper number 15, Clinical Psychology. 5 assumptions essential to the application of the definition. 1. Within the context of community environments typical of the individual's age, peers, and culture, limitation in present functioning must be considered. 2. Valid assessment considers differences in communication, sensory, motor and behavioral factors as well as culture and linguistic diversity. 3. Within individual, limitations coexists with strengths. 4. Develop a profile of needed supports as a critical purpose of describing limitations. 5. With appropriate personalized supports over a sustained period, the life functioning of the person with mental retardation will generally improve. Mildly retarded individuals constitute the large Mildly retarded individuals constitute the largest number of those diagnosed as mentally retarded. With the help, a large majority of them master simple occupational and social skills, adjust socially, and become self-sufficient persons. They do not show signs of other physical abnormalities or brain pathology, but they require some supervision because they have limited ability to foresee the consequences of their actions. With early diagnosis, special education, parental support, majority of them adjust socially and settle in their occupation and become self-supporting persons. They are able to master certain skills such as cooking and other skills under some specialized instructions in them. In adult life, they attain intellectual levels similar to those average 4 to 7 year of children. They usually appear to be inept and they suffer from bodily impairment and poor motor coordination. They could not master academic skills but could learn rudimentary vocational skills. They can be taught, read and write a little, and may manage a fair command of spoken language. Their rate of learning is slow. Some of these are aggressive and hostile but are non-threatening. With early diagnosis, in short parental help and with appropriate training, most of them can achieve partial independence in daily self-care activities and acceptable behavior in a family or other sheltered environment. They would not benefit from academic or vocational instructions. In these individuals, speech and motor development are severely retarded, motor and sensory handicaps are common. They can develop limited. Psychology paper number 15, Clinical Psychology. Level of personal hygiene and self-care skills, but are always dependent upon others for care. Some of them can perform single occupational task under supervision. Most of them are severely deficient in flexible behavior and are not able to master any skill. Central nervous system pathology, severe physical deformities and retarded growth are typical. Mutism, convulsive seizures, deafness and other physical abnormalities are also common. These individuals remain in custodial care all their lives. They tend to have poor health, a short life expectancy and low resistance to disease. These individuals show a marked impairment of overall intellectual functioning. 5. Etiology of mental retardation. There are literally hundreds of known causes of mental retardation. Some cases of mental retardation occur in association with own organic brain pathology, Kasky 2000. We will discuss 5 biological conditions that may lead to mental retardation. 5.1 Genetic or chromosomal influences. Mental retardation, especially mild retardation, tends to run in families. Genetic factors clearly is an important factor in the etiology of mental retardation. Almost 300 genes have been identified as having the potential to contribute to mental retardation, and it is expected that there are many more. Inflow and Restifo, 2004. The most common form of mental retardation, Down syndrome, was first identified by the British physician Langdon Down in 1866. Down had tried to develop a classification system for people with mental retardation based on their resemblance to people of other races. He described individuals with this particular disorder with as Mongoloid, because they resembled people from Mongolia. Schierenberger .1983. The disorder is caused by the presence of an extra 21st chromosomes and is therefore sometimes referred to as Down syndrome or trisomy 21. Psychology paper number 15, Clinical Psychology. Figure 1, showing Down syndrome is caused by the presence of 3 copies of chromosomes. The normal complement of chromosome is 23 pairs. There are 3 copies of chromosome 21 in Down syndrome. People with Down syndrome have characteristic facial features such as oval upward slanting eyes, and short and stocky nature, a flat nose and a small mouth with a flat roof and short broad hands. Heart problems are being experienced by about 40% of the children with Down syndrome. Tragically, nearly all adults with Down syndrome past the age of 40 show signs of dementia of the Alzheimer's type, a degenerative brain disorder that causes impairment in memory and other cognitive disorders. The incidence of children born with Down syndrome has been tied to maternal age. As the age of the mother increases, so does her chances of having a child with this disorder. A woman with age 20 has 1 in 2,000 chance of having a child with this disorder. At the age 35 the risk increases to 1 in 500, and at the age of 45 it increases again to 1 in 18. Burts, Evans and Hamerton 1985. Hook, 1982. The reason for the rise in incidence with maternal age is not clear. Some suggests that mother ova are all produced in youth. The older one have been exposed to toxins, radiation and other harmful substances over longer periods. This exposure may interfere with the normal division of the chromosomes, creating an extra 21st chromosomes. Puchel and Goldstein, 1991. Others believe the hormonal changes that occur as women age are responsible for this error. Fragile W syndrome is another chromosomal abnormality that can cause mental retardation. An abnormality on the X chromosome leads to this disorder. A mutation that makes the tip of the chromosome appears as though it were hanging from a thread, giving it the appearance of fragility. Large underdeveloped ears and a thin long face are the physical features associated with Fragile X. Many people with this Fragile X syndrome have mental retardation. Others with average IQ show problems such as learning disabilities, difficulties on neuropsychological tests and mood disabilities. About a third of children with this syndrome also exhibit autism spectrum behavior. Hagerman, 2006. 5.2 Recessive gene disease. A lot of recessive gene disease have been classified. Many of them are the cause of mental retardation. Phenylketonuria (PKU) is one such recessive gene disease. In PKU, an infant without clear signs of difficulty soon starts to experience a lack of a liver enzyme, phenylalanine hydroxylase. This enzyme is required to convert phenylalanine, an amino acid present in protein, to tyrosine, an amino acid that is important for the production of epinephrine. Because of lack of this enzyme and its derivative, phenylpyruvic acid, are not broken down and instead build up in the body's fluids. This buildup subsequently damages the brain, the neuron of the frontal lobes, the site of many. Psychology paper number 15, Clinical Psychology. Significant cognitive functions, such as decision-making, are specifically affected and causes profound mental retardation. This disorder occurs in about 1 in 12,000 births. Deben Ahmed, 2000. If the condition is not detected, the amount of phenylalanine in the blood increases and eventually produces brain damage. This disorder becomes apparent between 6 and 12 months after the birth, although such symptoms, vomiting, a peculiar odor, infantile eczema, and seizures, may occur during the early weeks of life. The early detection of this disease can be done by urine examination. A diet low in phenylalanine are to be provided by the parents. They are encouraged to give a special diet to the child. 5.3 Infectious disease. The fetus is at a risk if the mother is caught with infectious disease such as rubella, German measles. Physical deformities and mental retardation can be caused in fetus. Effects on the fetus are disastrous. On the other hand, mother may experience slight or no symptoms. After birth, child's developing brain is also affected by infectious disease. Encephalitis and meningococcal meningitis may cause brain damage and even death in contracted in infancy or early childhood. Infections are less severe in adulthood. 6. Accidents. Accidents are the major cause of disabilities and death in children over 1 year of age in USA. Injuries caused by falling. Vehicular accidents are among the most common in early childhood, may cause head injuries leading to varying degree of mental retardation. 7. Environmental hazards. Several environmental pollutants are implicated in mental retardation. Some pollutants are paints, which are lead-based, exhaust and smog from automobiles, which can cause brain and kidney damage. Ignored or neglected infants suffer irreversible learning impairments who are not provided the required mental and physical stimulation required for normal development. Children who live in poverty and unhealthy living conditions suffer from malnutrition and had improper or inadequate medical care are at a higher risk. 8. Psychological and social dimensions. Up to 75% of the mental retardation cases fall in the mild range and are not associated with the genetic and physical disorders. Children suffering from familial cultural retardation have thought to have cognitive impairment, and it results from a combination of psychosocial and biological factors. The cultural influences that contribute to this illness includes abuse, neglect, and social deprivation. 9. Treatments. Direct biological treatment is not a viable option. A number of programs have demonstrated that significant changes in the adaptive capacity of mentally retarded children are possible through special education and other rehabilitative measures. Burney, 2000. The degree of change is dependent on individual's situation and the level of mental retardation. 9.1 Residential treatment. Significant and orderly steps have been made to educate these children so that they can obtain proficiency to function adequately in the society. Mental retarded people have legal rights to adequate treatment in the less opposed place. They are given training under supervision. They are encouraged to get involved with the household work. Many of the adults are able to earn and live all by oneself in their own place. Others live semi-independently, and generally counselor provides aid in the evening. Psychology paper number 15, Clinical Psychology. There is general agreement about what should be taught to people who are suffering from mental retardation. The controversy in recent years has been over where they should be taught. Should people with severe retardation be taught in separate rooms, especially designed for them, or they should be allowed to work in shops? 9.2 Behavioral treatment. People with mental retardation can acquire skills through behavioral techniques to teach such basic self-care as dressing, bathing, feeding, and toileting to people with even the most severe disabilities. People are taught skills. Performance in each step is encouraged by incentives. For feeding themselves, going for toilet, and grooming, children with severe mental retardation need rigorous training. Operant conditioning techniques are used to teach children. It is also applied for reducing improper and self-injurious behavior. Constant improvement is shown in self-help skills and fine motor skills with the help of these programs. 9.3 Cognitive treatment. Children suffering from mental retardation are unable to apply problem-solving strategies even when they use it. They are unable to use it adequately. Children are taught through self-instructional training. They were awarded with praise when they solved their problems correctly. In solving a problem, the steps will be demonstrated by the teacher. Research has shown that self-instructions on how to solve a problem benefit people with severe mental retardation. 9.4 Education and inclusion programming. Educational and training procedures involves personal grooming, social behavior, basic academic skills, and simple occupational skills. Specific skills are divided into simple components that can be learned before more complex behaviors are required. 9.5 Computer-assisted instruction. In educational and treatment settings of all kind, computer-assisted instructions are increasingly found, and it could be useful to educate the mentally retarded people. The visual and auditory programs of computer attract the children. They can be used to teach mentally retarded children. To summarize, there are various steps that can be taken to treat mental retardation. In early childhood, proper nutrition should be given to the children. Even severely retarded child may improve greatly to a favorable social, emotional, and intellectual environment. 10. Summary. DSM-IVTR includes categories of mental retardation: mild, moderate, severe, and profound, on the basis of IQ scores. Identifying an individual's strength and weakness is considered to be important by AAIDD. Brain injury, chromosomal abnormalities, toxins, and infection are considered to be known causes of mental retardation. Poverty and nutrition are assumed to play an imp role in milder forms of mental retardation. When serious organic brain impairment occurs before the age of 18, the cognitive and behavioral deficits experienced are referred to as mental retardation. Relatively common forms of such mental retardation, which in these cases is normally at least moderate in severity, include Down syndrome, phenylketonuria PKU, and certain cranial anomalies. The organic forms of mental deficits accounts for only 25% of all cases of mental retardation diagnoses, regardless of the underlying origins of the deficit, are classified on axis 2 of DSM-IBTR. Pervasive developmental disorders is one of the serious disorders that is difficult to understand and treat, as people with these disorders experience a wide range of problems related to socialization, language, and cognitions. The word pervasive reiterates the fact that this disorder lingers on throughout the lives of the affected individuals. Examples of pervasive development disorders are autism, Rett disorder, Asperger's syndrome, and childhood disintegrative disorder. The focus here is on the two of the more prevalent disorders, autism and Asperger's disorder. Pervasive developmental disorder makes up about 3.2% of cases seen in inpatient settings. Spurd, Sheff, Fuss and Levine, 1995. They are considered to be the result of some structural differences in the brain that are usually evident at birth or become apparent as the child begins to develop. Siegel. DSM-IBTR or ICD-10 have a fairly good diagnostic determination of pervasive developmental disorders in children. Several pervasive developmental disorders are covered in DSM-IBTR. Asperger's disorder includes marked stereotypic repetitive behavior and inflexible adherence to routines, which results in a severe and persistent impairment in one's social interaction. Mezabov, Shea and Adams, 2000. This patterns of behavior usually appears later than other pervasive developmental disorders such as autism. It nevertheless leads to a long-term psychological disability. Asperger's disorder shares many features of social impairment disorder, but in most cases it is not associated with the severe delay in language development and social interaction that autism does. Kozam, A. Gabalawi, ed. Al. 2004. 3. Asperger's disorder. Asperger's disorder, named after Hans Asperger, who in 1944 described the syndrome as being less severe with few communication deficits than autism, is thus a mild form of the latter. Stereotyped behavior is found to be intense and social relationships are poor. However, language and intelligence is not affected in patients with Asperger's disorder. It is unclear that whether Asperger's is quantitatively or qualitatively different from autism. Autism and Asperger's disorders are considered two types of a pervasive developmental disorder, a term first introduced in DSM-3. Psychology paper number 15, Clinical Psychology. 3.1 Diagnostic criteria for Asperger's disorder, DSM-IBTR, figure 1 showing diagnostic criteria for Asperger's disorder. A qualitative impairment in social interaction is reflected as a manifestation of at least two of the following in the individual's behavior. 1. Nonverbal behavior is reflected through facial expressions, eye gaze and bodily postures have significant impairments. 2. Inability to develop meaningful relationships with peers per their level of development. 3. There is a significant lack of spontaneity to share enjoyment, interests or achievements with other people. 4. Absence of social or emotion-based reciprocity in relationships. B. Further, there is a stereotypical and restricted repetition of patterns of behavior is reflected in one's behavior, interests or activities, manifested by at least one of the following. 1. Persistent preoccupation with one or more restrictive or stereotypical pattern of interest that is abnormal either in its intensity or focus. 2. An overtly inflexible adherence to specific routines which are apparently non-functional. 3. Persistent repetitive and stereotypical patterns of behavior reflected in motor mannerisms of the individual basically through complex body movements. 4. Continual and persistent preoccupation with certain objects, parts of such objects. See, these persistent and repetitive patterns of behavior cause significant disturbance of one's social, occupational and other areas of functioning. D. Further, there is a marked delay in development of adaptive behavior, curiosity regarding the external stimulus and cognitive development of the individual. E. Above criteria not being met for another specific pervasive developmental disorders or schizophrenia. Sources. With permission from American Psychiatric Association, 2000. Diagnostic and Statistical Manual of Mental Disorders. 4th edition. Text revision. 4. Clinical descriptions of autism. Autism was identified by Leo Kanner, a psychiatrist at Johns Hopkins University, studied the behavior of 11 disturbed children who behaved in a way that was uncommon among children with. The behavior of these children was characterized by an extreme autistic aloneness which led him to naming this disorder as autism. Kanner, 1943. Psychology paper number 15, Clinical Psychology. Autistic people exhibit a wide range of problematic behavior including deficits in language, perceptual and motor development and inability to function in social situations. Autism is usually identified before the child is 30 months of age. Mothers often remember such babies as never been cuddly, never reaching out when being picked up, never smiling or looking at them. 4.1 Social deficits and emotional disturbances. Autistic don't show any need for affection and contact with others. They avoid others. They do not understand social cues from others. Complete mind blindness is found in them. They see things as others see them. Few autistic initiate to play with others. These children have significant impairments in nonverbal behavior as they are unable to make eye contact and often unresponsive. Even when they do make eye contact, their gaze has a measure of a rather unusual quality. Further, these children do not display curiosity towards their external stimulus or environment and rarely gaze at individuals to get their attention or to draw their attention to a particular object. Dawson et al.2004. This is often referred to as a problem in joint attention. That is, interactions that require two people to pay attention to each other. Studies indicate that autistic children are unable to pay attention to others, which is further reiterated by no activation found in the brains of such children during these tasks. They were found less efficient in studying the emotions and expression of others. They do not enjoy physical activity like wrestling and tickling, nor do they engage in symbolic play. If another person initiates play, then they might engage in the activity but only for some time. Some of them may not be able to differentiate one person from another but may develop strong attachment to inanimate objects like keys, switches or blankets. If the object is small in size, they may carry it around with them, which further prevent them from learning to do more useful things. Research shows how social awareness problem evolves as the children grow older. In one study, scientists showed an adult man with autism scenes from some movies and compared how he looked at social scenes with how a man without autism do so. Klin, Jones, Volkmer and Cohen, 2002. This research suggests that people with autism may not enjoy meaningful relationships with others. Autistic children are unable to understand other people's perspective and emotional reactions. 4.2 Intellectual ability. Autistic children do not perform well on cognitive and intellectual tasks. They are significantly impaired on memory tasks. They appear to have deficits in social reasoning but can manipulate objects. Some autistic are quite well at fitting objects and their performance on puzzles may be average or above. When autistic children are shown pictures and asked to make a story, they show marked deficiency in performance. 4.3 Communication deficit. Some autistic children show deficits in language and some of them show deficits in communication. They do not learn from imitation. 1/3 of these children never acquire speech. The ones who have acquired speech are often very unusual in much of their communication. Some repeat the speech of others, a pattern called echolalia we referred to before as a sign of delayed speech development. If you say, "My name is Ram, what's yours?" they will repeat all or part of what you said. Ram is my name. Some who can speak are unwilling to carry on conversation with others. Pronoun reversal is a common speech abnormality in autistic children wherein they refer to themselves in third person as he, she, or you, or even by referring to themselves by their. Psychology paper number 15, Clinical Psychology. Own name. This abnormality is linked to echolalia wherein they refer to themselves as they have heard others speaking to them, as a result of which, they misapply pronouns. 4.4 Restricted behavior, interest and activities. Autistic children have restricted pattern of behavior, interest and activities. They like things to be the same. They become extremely upset even if a small change was introduced. This intense preference for the status quo has been called maintenance of sameness. When anything familiar in the environment is altered even slightly, these children may have a violent temper tantrum or crying spell that continues until the familiar situation is restored. Thus, autistic children are obsessed with the maintenance of sameness. They spend countless hours in stereotyped and ritualistic behaviors, making such stereotyped movements in circles, waving their hands in front of their eyes with their heads cocked to one side. 4.5 Self-stimulation. Self-stimulation is often characteristic of autistic children. It usually takes the form of such repetitive movements as head banging, spinning, and rocking, which may continue for hours. Other bizarre movements and repetitive behavior as are typical. Autistic children seem actively arrange the environment on their own terms in an effort to limit interventions of other people prefer instead a limited and solitary routine. 4.6 DSM-IVTR criteria for autistic disorder. A 6 or more of the following criteria from 1, 2, and 3 with at least 2 from 1 and 1 each from 2 and 3. 1 Qualitative impairment in social interaction, as manifested by at least 2 of the following. A presence of significant impairment of one's nonverbal behavior in the form of their facial expressions, body language, body postures and gestures, eye gaze, etc., which regulates social interaction. Further, there is an inability to develop appropriate relations with one's peers. B. Lack of interest in sharing achievements and enjoyment with other people. For example, lack of sharing or pointing out objects or situations which spark curiosity or interest. 2. Qualitative impairment in communication is manifested by at least one of the following: a delay or a total lack of development of spoken language in the individual, accompanied by a further lack of communicating through alternate means of communication such as gestures. B. In individuals with adequate speech, there is a significant impairment in the ability to initiate a conversation with others. C. Stereotyped and repetitive use of language. D. Lack of varied, spontaneous make-believe play or social imitative play appropriate to one's developmental level. 3. Restricted repetitive impairments and stereotyped patterns of behavior, interest, and activities, as manifested by at least one of the following. Psychology paper number 15, Clinical Psychology. A preoccupation with one or more stereotyped and restricted patterns of interest that is abnormal either in intensity or focus. B. Overt inflexibility to adhere to specific routines or rituals which are more often than not non-functional. C. Stereotyped and repetitive motor mannerisms, e.g., hand or finger flapping or twisting, or complex whole body movements. D. Persistent preoccupation with parts of objects. B. Delays or abnormal functioning in at least one of the following areas, with onset prior to age 3 years. 1. Social interaction. 2. Language is used in social communication, or 3. Symbolic or imaginative play. Source: adapted with permission from Diagnostic and Statistical Manual of Mental Disorders, 4th edition. Text revision copyright 2000, American Psychiatric Association. 5. Causal factors in autism. Biological dimensions. Biological, psychological and social factors are implicated in the development of autism. Empirical evidences support genetic influences. 5.1 Genetic influences. Genetic factors contributed in the development of autism. It was found that in a family, if one child suffers from autism, there is a 5 to 10% chance that the other child will also suffer from the same disorder. It is not yet clear which genes actually leads to the disorder. Researchers are doing work on oxytocin, because it plays an important role in our social memory and in our social bonding with others. There is evidence for some involvement with numerous chromosomes. Researchers are seeing whether genes responsible for this neurochemical are involved with autism. Preliminary work identifies an association between autism and an oxytocin receptor gene, Jacob et al. 2007. Some researchers have pointed to the existence of a possible genetic defect known as Fragile X, a constriction or breaking off of the end portion of the long arm of the XX chromosomes that appears to be determined by a specific gene defect. The Fragile X syndrome occurs in about 8% of autistic males. In addition to that, 15 to 20% of males with the Fragile X syndrome are also diagnosed with autism, further suggesting a link between the two syndromes. 5.2 Neurobiological influences. Many neurobiological factors are being studied to help explain the social and communicational problems observed in autism. Researchers have found the brain of adults and children with autism to be significantly larger in comparison to that of adults and children without autism, which have been supported by further studies which use the measurement of one's head circumference as an indicator of brain size. These findings suggest that children with autism are, though born with brains of a relatively normal size, they, however, between the ages of 2 and 4 have brains significantly larger than those of children without autism. This establishes the fact that a larger brain size is not necessarily a good thing, as it indicates that the neurons are not pruned correctly, and the latter is essential for the maturation of the brain. Along with a larger brain size, the brain growth of autistic people is significantly lower in later childhood, which establishes a direct connection between the patterns of brain growth to autism. The overgrown. Psychology paper number 15, Clinical Psychology. Areas of the brain are frontal, temporal and cerebellar, which are linked to language, social and emotional functions. 16 MRI and autopsy studies from 9 independent researchers have found abnormalities in the cerebellum of children with autism. Neurological abnormalities among autistic people suggests that in the course of development, their brain fails to align properly and does not form the necessary connections found in normal brain. It was also found that the amygdala in autistic children was found to be larger in size, which is found to be associated with social and emotional behavior. 6. Treatment of autistic disorder. Psychological treatment is found to be most successful in treating autistic children, even more so than prescription drugs, as it improves their social and communication skills while reducing unusual behavior. 6.1 Behavioral treatment. Operant conditioning techniques are used to mainstream autistic children. The results from the study are dramatic and encouraging, as intensive training groups showed gains in IQ. Behavioral treatment was found to be more effective than parents training alone. Early psychodynamic treatment were based on the belief that autism is the result of improper parenting. It was found that treatment based solely on ego development did not have a positive impact on the lives of the autistic. Greater success has been found to be achieved through behavioral approaches than the focus on skill building and behavioral treatment. The first skill that was used with autistic children was to imitate other people's speech, which can be achieved through reinforcing the child with praise. 6.2 Biological treatment. No one medical treatment has been found to cure autism. Medical interventions have had little success on the core symptoms of social and language difficulties. A variety of pharmacological treatments are used to decrease agitation, and major tranquilizers and serotonin-specific reuptake inhibitors seem helpful. Volkmar, Klin, and Schultz, 2005. Autism may result from a variety of deficits. It is unlikely that one drug will work for every autistic. The most common medicine used for treating this disorder is haloperidol, an antipsychotic drug used in treating schizophrenia. Some studies have shown that this drug reduces social withdrawal, stereotyped behavior, and such maladaptive behavior as self-mutilation and aggression. Drugs that reduces the action of serotonin are used in the treatment of autism. Researchers have found that naltrexone, an opioid receptor antagonist, reduces hyperactivity in children with autism and produces a moderate in the initiation of social interaction. 7. Summary. Autism is found to be most disturbing disorder among children than the other childhood disorders DSM-IV described as pervasive developmental disorders. Autistic show marked impairment in social skills. They show deficits in establishing social relationships with others. They do not use nonverbal cues such as eye contact. They do not establish eye contact with others. They have poor language skills. They do repetitive patterns of behavior. These children seem to live in their own world. They show no interest in others. They live in their own world. Brain dysfunction R. Psychology paper number 15, Clinical Psychology. Found in them. Their frontal lobe is less developed. Psychological treatment was found to be useful than medicines. Importance of academic. The importance of academic achievement can be traced highly in Indian society, especially on the parents' part, by pushing the children to do better through constant peer group comparison. On the other hand, it may be disheartening for the children to undergo such mental conflicts and come up to their parents' expectations without having any intellectual deficits. Thus, no matter how much time and efforts the parents are investing in the child, sometimes the desired results are yet not achieved. This gap, when becomes highly difficult to meet or the learning becomes inadequate, a situation called retardation arises, also known as delayed development, which may be manifested through language, speech, mathematical, or motor skills. Learning disability should not be confused as one caused due to physical or neurological defects. Though not used by DSM-1-BTR, a high percentage of health professionals believe in categorizing the disorders into 3 groups: learning disorder, communication disorder, and motor skills disorder. Those lacking in the above-mentioned areas, up to an adequate degree, will be categorized as having the area-specific disorder. Thus, those children who fall below a significant level in, say, reading ability, compared to the children of the same age group, cognitive ability and educational background, are likely to be characterized with this disorder. This disability should not be diagnosed on the basis of any sensory difficulty, say, poor vision or auditory disturbances, or as a result of poor instructions. No matter which learning disorder (LD) it is, 2 aspects are surely affected: academic achievements and daily life activities. 3. Prevalence of learning disability. In India, approximately 10% of children are estimated to have learning problems, out of which 4.6% of school-age students are identified as severely disabled. More boys were found to have learning disability than girls. An older study showed that this disorder has little higher prevalence in boys. Shaywitz.et. Al. 1990. However, the current studies have found that reading disorders are more prevalent amongst girls than in boys. There is a lack of exact statistics on the number of children requiring educational support in India. However, it has been estimated that about 12.5 million children with disabilities are to be provided education in the school system. Out of these, 3.6 million are children with learning disabilities falling in the age group 5 to 14 sample survey, 1981. According to the observations made, there is a lack of spontaneity in efforts to find out the prevalence of LD in India. Also, it has been strongly found that 10 to 12% of India's school children are with learning disabilities. The medium through which these children can be evaluated is mostly through examination that are written in nature. This poses as a drawback to evaluate a child who has learning disability. Another vital issue is identification of learning disabled. It is difficult to tap this disability difficulty since some of its Psychology paper number 15, Clinical Psychology. Characteristics overlap with other conditions such as borderline intelligence. Many times, the educators and administrators seem confused with its diagnosis. Though the most popularly used definition gives a comprehensive description of inclusion and exclusion, there is no single test that can clearly differentiate LD from other conditions. According to a study by Alterac and Saroha, 2007, USA is found to have a specific learning disorder, which is afflicted on about 6 million children. The most popular learning disorders being reading difficulty, occurs amongst 4% to 10% in general population. Mathematic disorder, appearing in approximately in 1% of the population, while there is limited information about the prevalence of disorder of written expression among children and adults. Early studies indicated that boys were more likely to have reading disorder than girls, although more contemporary studies indicates that boys and girls may be equally affected by the disorder. Students with learning disability suffer in almost all the important domains of their lives, such as academic dropouts from school, occupational, likely to be unemployed, and personal, suicidal thoughts and even attempt suicide. Daniel et al. 2006. Interviews with adults who have learning disabilities reveal that their school experiences were generally negative and the effects often lasted beyond graduation. Some verbal or communication disorders have also seemed to be closely related to learning disorders. Such disorders are benign in nature, however, when prevalent early in life, they can be harmful for life. 4. Learning disorder in DSM-IBTR. Learning disorder includes 3 categories. 4.1. Reading disorder, widely popular by the name of dyslexia. This disorder involves difficulty in reading and understanding words, sentences, and paragraphs, such reading a comprehension, recognizing words, and writing the spellings. 4.2. Disorder of written expression. It involves an impairment in the ability to write, including spelling error in grammar and punctuation, and very poor handwriting. 4.3. Mathematic disorder. It involves the difficulty in calculating, understanding, and manipulating numbers, such as correctly counting objects, recalling the arithmetic facts rapidly and accurately, etc. 4.4. Communication disorder. 4.4. Communication disorders include 3 categories. 4.3. Mathematic disorder. It involves the difficulty in calculating, understanding, and manipulating numbers, such as correctly counting objects, recalling the arithmetic facts rapidly and accurately, etc. 4.3. Mathematic disorder. It involves the difficulty in calculating, understanding, and manipulating numbers, such as correctly counting objects, recalling the arithmetic facts rapidly and accurately, etc. 4.4. Communication disorders include 3 categories. 4.5. Expressive language disorder. It involves the difficulty in expressing oneself through the medium of speech, such as difficulties in word finding, speaking in phrases only by the age 4 and below age level, use of grammar. The prevalence rate is 10% to 15% amongst the children younger than 3 years of age. Johnson and Weichman, 2005, and is approximately 5 times likely to affect boys as compared to girls. Whitehurst et al., 1988. Some hold the lack of attention by parents as the reason behind this disorder. On the other hand, the biological theory considers the middle ear infection as a cause behind this. This disorder may be a self-correcting and may not require special intervention. 4.6. Phonological disorder. Sometimes, despite of the ability to correctly comprehend the language and sufficiently use the vocabulary, there is a delivery of a speech which is unclear in. Psychology paper number 15, Clinical Psychology. Has an improper articulation. For example, the word blue becomes bu, and rabbit sounds like wabbit. With speech therapy, usually complete recovery occurs in almost all the cases. However, the cases with moderate level of this problem may recover spontaneously by the age of 8 years. 4.7. Stuttering. Stuttering is a disturbance of verbal fluency characterized by one or more of the following speech patterns, such as repetition of the sounds frequently, words, and producing easy substitute words for those that are difficult to form and say. It is twice more prevalent in boys as compared to girls. According to the prevalence rate reports, stuttering usually begins amongst children who are under the age of 3, and 98% of these cases occur before the age of 10. According to Kroll and Weichman, approximately 80% of the children who stutter before they enter school will no longer stutter after they have been in school for a year or so. Thus, the direction of the relationship changes, that is, it is the stuttering makes one socially anxious and not the other way. Genetic factors and brain abnormalities are considered to be the contributors in this disorder. Kroll and Weichman, 2005. According to DSM-1BTR, approximately 80% people with stuttering recover before the age of 16 even without seeking any medical intervention. During the treatment, parents are most importantly roped in to discuss about how to talk to their children. Further, other methods can be sought as a part of treatment, such as regulated breathing method, a part of behavioral treatment. Here, the person is instructed to stop speaking when a stuttering episode occurs and then to take a long breath, exhale and then inhale before proceeding. Woods, Fuqua and Hanley, 2000. According to few researches, altered auditory feedback to people can improve their speeches can using forms of self-monitoring, in which people modify their own speech for words they stutter. Ben Katagiri, 2005. Sources. Reprinted with permission from American Psychiatric Association. 2005. Causes of learning disabilities. The prevalence rate of learning disability disorder in school-age children is about 5 to 10%. Gradually, studies on mathematics disorder are also emerging, though at a little slow pace. Dyslexia is the limelight of the maximum researches on learning disability, mainly because of its high prevalence than the other disorders of this group. 5.1. Cause of dyslexia. In dyslexia, the problem is manifested in word recognition and reading comprehension, often being markedly deficient in spelling. Such people have poor reading skills, such as routinely omitting, adding, and distorting words, along with having a painfully slow and halting reading. Dyslexia consists of some genetic component that can pass on from one generation to another, according to twin studies and family studies. Pennington, 1995, Raskin. 2001. Furthermore, the genes that are associated with dyslexia are the same genes associated with typical reading ability. Evidence gathered from psychological, neuropsychological, and neuroimaging studies suggests that people with dyslexia have a core deficit in language processing. Furthermore, there are several language-related issues which can highlight the problem of dyslexia, such as analyzing the sounds of spoken language and associating their relation to printed words. Mann and Brady, 1985. Some Psychology paper number 15, Clinical Psychology. 1. Learning outcomes. After studying this module, you shall be able to 5. Causes of learning disabilities. The prevalence rate of learning disability disorder in school-age children is about 5 to 10%. Gradually, studies on mathematics disorder are also emerging, though at a little slow pace. Dyslexia is the limelight of the maximum researches on learning disability, mainly because of its high prevalence. 5. Causes of learning disabilities. The prevalence rate of learning disability disorder in school-age children is about 5 to 10%. Gradually, studies on mathematics disorder are also emerging, though at a little slow pace. Dyslexia is the limelight of the maximum researches on learning disability, mainly because of its high prevalence than the other disorders of this group. 5.1. Cause of dyslexia. In dyslexia, the problem is manifested in word recognition and reading comprehension, often being markedly deficient in spelling. Such people have poor reading skills, such as routinely omitting, adding, and distorting words, along with having a painfully slow and halting reading. Dyslexia consists of some genetic component that can pass on from one generation to another, according to twin studies and family studies. Pennington, 1995, Raskin. 2001. Furthermore, the genes that are associated with dyslexia are the same genes associated with typical reading ability. Evidence gathered from psychological, neuropsychological, and neuroimaging studies suggest that people with dyslexia have a core deficit in language processing. Furthermore, there are several language-related issues which can highlight the problem of dyslexia, such as analyzing the sounds of spoken language and associating their relation to printed words. Mann and Brady, 1985. Some may even encounter difficulty in recognizing rhyme and alliteration. Bradley and Bryant, 1985. Problems with rapidly naming familiar objects. Scarborough, 1990. Wolf, Valley and M. Morris, 1986. As amongst the other consequences of this disorder. Much of these processes fall under the umbrella term of Psychology paper number 15, Clinical Psychology. Phonological awareness, an important source for instilling skills like reading. Anthony and Lonergan, 2004. Studies using various brain imaging techniques have validated this information that children with dyslexia have a problem in phonological awareness, especially those same regions which are involved in dyslexia. MRI studies have found that dyslexic children fail to activate their temporoparietal area during a task of phonological processing. Temple.et.al, 2001. They also show less activation in the temporoparietal area of left hemisphere and occipitotemporal areas while doing a number of reading-relevant tasks. Shaywitz et al. 2002. A treatment study has showed that after a year of intensive treatment for reading problems, children with dyslexia were better readers and showed greater activation in the left temporoparietal and occipitotemporal areas while completing a reading task, compared to a group of children who received a less intensive treatment. Similar findings using MRI have been found among dyslexic adults. Horwitz, Ramsey, 1998, Klingberg et al. 2000. A study conducted on adults through MRI examined 3 different types of readers. Shaywitz.et.al. 2003. Persistently poor readers. PPR group, who had trouble reading in early and later school life. The accuracy improved. AI group, who had trouble reading in early school life but not later. And the non-impaired readers, NE group, who had no trouble at all. The results showed that the PRR group performed poorly on the behavioral reading as compared to the AI and NI group. It was also seen through repeated testing that the AI group performed equivalently well to the NI group, thus suggesting that the AI readers had improved over time and thus became better in their later school life as compared to earlier performance in school. Identification of a gene region for dyslexia on chromosome 6 has been reported. This study was done with the English-speaking children and adults in the United States. However, a similar study done on Chinese children with dyslexia not only failed to find a problem with the temporoparietal area of their brain while reading tasks, their left middle frontal gyrus also showed less activation. Sayek et al., 2004. With this, the investigators speculated that it is because of the differences between Chinese and English languages which is responsible for the activation of different brain regions. This is because English is a language which is characterized by words. These words represent the sound. Whereas, Chinese language is characterized only through the symbols, about 6,000 different symbols in total which represent the sounds. This makes the Chinese process the reading material visually, whereas the English do so through sound processing. 5.2. Cause of mathematic disorder. The only twin study ever conducted on the heritability of mathematic disorder shows a heritability estimate of 0.38. Alicorn.et.al., 1997. Some researches show that genetic factors also influence the individual variations in math skills. Heritability is mostly considered as the reason behind math disability, which involves poor semantic memory. Studies indicate that any genes associated with mathematic disorder are also associated with mathematic ability. According to studies, there are some common genetic factors which are responsible for math deficits in children with both disorders. Gillis and DeFries, 1991. Furthermore, as with reading disorder, the evidence suggests that any gene associated with mathematics disorder or associated with mathematic ability Plomin and Cobus.2005.